So let's start from permacol paste. Permacol paste is a new biomaterial made by a cellular cross-linked porcine-dermal collagen matrix milled and suspended in saline solution. It has better protein stability with more resistance to enzymatic degradation in vivo and conforms to the fistula tract by providing an internal matrix to facilitate neovascularization. It allows also the time necessary for the host tissue to deposit its extracellular matrix. What about the technique? First of all, we put the ceton, and so we perform the ceton removal, a gentle debridement of the fistula tract, the preparation of the internal orifice for the closure with a stitch on the smooth muscle covered by a side-to-side mucosal flap. Then we introduce the cannula inside the tract using a guide wire. The liquid porcine dermal matrix is then injected through the external opening into the fistula tract. We perform the closure of the external and the internal opening in order to prevent early leakage of the biomaterial. And the paste was injected until the tract is completely filled. The video we will see later. Now we talk about the first experience about this paste. It showed a good biointegration in a full-thickness punch biopsy without any significant inflammatory cell infiltration, a good early neovascularization. This is another experience about the use of this paste alone or added to fibroblast advancement flap on porcine models, and all the 29 tracts that were reamed and treated with the collagen paste, with or without other cells, showed complete healing with a good cellular migration. And here I reported a review of the literature of the papers published about, starting from the first two about this technique published by Sileri in 2010 and 2012, with a good success rate, 91 and then 75, with a difference from Crohn's-related and non-Crohn's-related fistula. Then we have our paper published in 2017, about 21 patients followed up for 1 year with controversial results. I mean, less than half healed completely at 1 year, 47.6%. Then in 2017 we have also the Maserati trial, 100 patients followed up for 1 year, and the overall healing rate is 53.5%, with 29% of adverse events and 4% of serious adverse events. The latest paper, 2018, Birac and Schiano di Visconti, with a good series, 30 and 46 patients. Schiano di Visconti also has follow-up for 2 years, and the overall healing rate is 77.4 for Birac and 50 for Schiano di Visconti, so half of the patient healed. The latest is from Brunner of this year, 30 patients, 1 follow-up, and all the patients were treated with ceton. They closed the internal orifice with a stitch, and the success rate was 63%, but counted only on 24 of the 30 patients. But among this series, 12 patients had Crohn's-related fistula, and 6 patients were rectovaginal fistula, so it is a mixed series of patients. So we can conclude that permacol paste treatment is a safe, minimally invasive, and sphincter-safe treatment for anal fistula. It promotes a good healing rate in approximately half of the patient, and is well perceived by the patient themselves, and further studies are needed. So, we go to talk about adipose tissue. Which are the benefits of the adipose tissue? It is easy to obtain with a minimally invasive harvest. It has high concentration of regenerative cells. In fact, from 1 gram of adipose tissue, 5,000 stem cells can be isolated, which is 500 times more than from an equivalent amount of bone marrow. And it has also less risk associated with autologous therapies. The adipose tissue is composed by the adipose niche, that is a native microenvironment containing adipocytes and other cells embedded in a collagen scaffold with a vascular network. These are the components of the niche: adipocytes, extracellular matrix, and most important, the pericytes. In fact, the pericytes are cells that are wrapped around capillaries and microvessels within adipocyte clusters and facilitate communication with cellular environment reacting to signals from injury. This is the proposed sequence of the response of a pericyte to the injury. We start from pericyte through mesenchymal stem cell activated with the potential regenerative. The pericytes show a trophic effect, secreting lots of bioactive molecules. In fact, it shows to have mitotic effect, angiogenic, anti-apoptotic, and also antimicrobial. The use of this mesenchymal stem cell has recently created a great interest. In fact, several studies show regenerative and immunomodulatory properties, both in vivo and in vitro. They've been already used in different surgical fields, such as reconstructive plastic surgery mainly at first, then urogynecological surgery, orthopedic, maxillofacial, vascular surgery, general and colorectal surgery. These are reported the important studies mainly about treatment of fistula and Crohn's disease. The enzymatic treatment or cell expansion have a large number of processing steps, significant cost, and complex regulatory constraints by GMP. So, the minimally manipulated autologous adipose tissue as a therapeutic option would be preferable. And we arrived to this device, the LipoGems, that got the FDA approval in December 2014. It is based on a gentle mechanical manipulation instead of enzymatic digestion. And this is the final product that is ready to inject. It is different from the common lipoaspirate because it has a smaller cluster, 0.3 and 0.7 millimeter. But the key points of this device is the fluid protection of the adipose tissue and the size reduction. Here I reported a study in which the LipoGem samples showed a maintained vascular stroma consisting in slit-like capillaries containing vascular channels. Conventionally, the treated fat showed instead compressed and distorted microchannels. And here it is showed how the expression of CD146 was significantly increased in the LipoGem samples. And this CD146 is co-expressed by endothelial cells and pericytes. Here another article in which it showed that the total amount of cytokines secreted by the common lipoaspirate decreased much more rapidly than those produced by the microfragmented adipose tissue. This is another paper in which also showed that the microfragmented adipose tissue has a significant enrichment in pericytes as compared to the enzymatically processed lipoaspirate and release many more growth factors and cytokines. So, the isolated mesenchymal stem cell managed the injury response by cytokine secretion. And the LipoGems does the same, but for a much longer time, thanks to the tissue graft, reducing inflammation and fibrosis and favoring the regeneration. So the key points are main vascular stroma niche maintaining, enzyme-free, and one-step procedure. This is the surgical technique. The entire procedure is carried out in one surgical step, as I said, harvesting the adipose tissue, processing the adipose tissue with this LipoGems device, the curettage of the fistula tract and closure of the internal opening. injection of the microfragmented adipose tissue around the fistula tract and the internal orifice. Here I reported our paper that was a pilot study assessing the safety and feasibility upon 19 patients with a follow-up of 9 months. The overall healing rate was 73.7%, with a difference from the first-line group, patient that has no previous surgery for fistula, 83.3%, and the recurrent group, 57.1%. So we conclude that it's safe, feasible, and a reproducible procedure. And these preliminary results suggest the use of the combined technique in patients with complex anal fistula at their first sphincter-saving procedure. Starting from this, we developed a pilot prospective observational study started in 2016. These are the inclusion and exclusion criteria, mainly a complex fistula already drained with aceton with the first sphincter-saving procedure patient. And the exclusion criteria are, as you see, all the others to try to clean our series of patients. It was concluded in 2018, and these are the final results, and the paper is under review. Total patient enrolled 30 with a follow-up homogeneous of 1 year, and the healing rate was 73.3%. These instead are the total results till yesterday. Total number of patients treated is 60, and I divided the patient in 3 categories. The recurrence patient, whose success rate was 44%. The first-line treatment patient, whose success rate is 78.1%. And the Crohn's disease patient, whose success rate was 60%. And starting from this again, we developed a prospective observational multicentric study with 100 patients who's to be enrolled with a homogeneous follow-up of 1 year and 10 centers involved. The objective is to assess the efficacy of the injection of autologous and microfragmented adipose tissue in perifistula tissue in patients with transphincteric fistula untreatable with fistulotomy. And the primary endpoint is the absence of secretion with total closure of the internal and external orifice at 1 year. These are the secondary endpoints, but I want to underline the last one, that is the non-inferiority of the proposed technique in terms of success and recurrence rate as compared with the conventional advancement flap. This is the latest article published by the group of Bologna on Crohn's disease. 15 patients follow-up 6 months, and the final results were 66.7% had combined remission, clinical and radiologic, and 26.7% showed an improvement. And we need also to deep the meaning of improvement about anal fistula. Okay, thank you very much.